Hello, I'm Sheryl McCarthy of the City University of New York. Welcome to One to One. Each week, we address issues of timely and timeless concern with newsmakers and the journalists who report on them, with artists, writers, scientists, educators, activists, social scientists, government and nonprofit leaders. We speak with each one to one. What could be a more timely subject than the state of our healthcare system and how our communities are helping or failing to help those who need health care the most? Former State Senator Catherine Abate is all too familiar with the subject. She's president and CEO of the Community Health Care Network, a group of not-for-profit health centers that provide medical, dental, and social services to underserved neighborhoods throughout New York City. Welcome.
I'm delighted to be here. Thank you.
It seems like just about every week one is reading reports about corruption among state and local elected officials, kickbacks, pay to play, pay for favoritism, pay for favorable legislation, pay to get on the ballot, nepotism, use of taxpayer money and campaign funds for personal and family use. Aren't you glad you're not a state senator anymore?
I think you answered my question, or answered the question you gave me.
Has the amount of corruption, has it always been this great, or has it been growing? What's going on?
Well, we're living in an internet age, and investigations and how we communicate with each other. I think it's a lot easier to catch people in their misdeeds. People are, when they are criminals, they're not really quite good at it. And there's a paper trail, whether it's emails or text messages, and then their wires used. I don't know whether it's more, but people are getting caught.
Okay.
It's hard to say.
Yeah, I guess it's a good thing that they're getting caught, but it's sort of hard on the morale.
But what's really regrettable, one misdeed, whether it's a crime or omission, misfeasance, malfeasance of a public official elected to do good, public good, it's intolerable. It's so unacceptable, and it brings down the good work of everyone else.
Right.
And that's what's happening now, and people forget there are some really dedicated, hardworking legislators in Albany that aren't making more than what their salary pays them, and it's not a large salary, and they come home to do their constituents' bidding, try to meet the needs of the communities they serve, but you rarely hear that much about those individuals.
Right.
So there's a gap there.
Yeah, yeah.
And we hear about the people we shouldn't be hearing about. They should go into oblivion.
You've had numerous jobs in public service. What led you to Community Healthcare Network?
When I was correction commissioner, spent a lot of time in the mental health wards. There was an AIDS epidemic during that time. So I was familiar with a number of the public health issues, whether it was TB and AIDS and a lot of the chronic diseases affecting the inmates that came through Rikers Island. And also in Albany, I was on the health committee. So it was one of the premier topics and concerns of everyone in New York State. It interested me, and I decided after I left the state senate, I would pursue something in healthcare, and I was lucky enough to get this position.
Tell us about what Community Healthcare Network is and what it does.
It was founded in 1981 as Community Family Planning Council. And at the time, HRA, which is the Human Resources Administration, was asked by the mayor to bring all these disparate family planning clinics together under one organization. And that's how the organization was founded. And in the beginning, there were many health centers throughout New York City providing reproductive health care and family planning services to women. Now, from 1981, which is its founding, till today, there was an evolution. I came to Community Healthcare Network in 1999, and a lot of the changes occurred before as well as after. But from just doing women's health, it evolved to providing care for children, HIV care, to the kind of care we provide today, which is full preventative care to everyone in the family, to men, women, children, well care, chronic disease management, mental health services, all kinds of social services.
And how many locations do you have? How many?
We
These
have
are basically what we'd call clinics, community clinics?
That's right, but they're federally qualified health centers, and they're designated. And they're very different from just any health center because they're designated, have to be approved, accredited. HRSA comes by all the time to look at the quality of the care, how cost effective we are, the scope of our services. Are we representing the community in terms of being friendly to the community, customer service, patient-centered? So all that, and there are 70 community health centers in New York State. And they're well-run and tailored to the needs of the community. For instance, many of the people who work in our health centers come from the community, speak the languages of the communities they serve, and are understanding the culture of the people we serve. So we have 13 health centers.
Okay, in New York City.
In New York City.
Now, how does one start a community health clinic? I mean, where does the funding come from? I would assume a lot of the money, there would be a lot of Medicare and Medicaid money. Do your clients also pay something?
Right. How it works is most of the funding comes from Medicaid. And I would say in most health centers, about 50% of the funding. The people that come through the doors are Medicaid eligible. Very little private insurance. And then there is a subset of uninsured, and that's the working poor that do not qualify for Medicaid and cannot afford private insurance. And for that category, there's a sliding fee scale. But no one is turned away. If you cannot afford $40 or $20 or $60 or $80, depending on your income category, we work with people. Sometimes people just can't afford it. They can pay for one member of the family, not another. So that's the hallmark of federally qualified health centers. No one gets turned away.
Now, is there also private money, local money? Because I would think that Medicaid funding would not pay all of the expenses for the doctors, for the total
You're
services.
absolutely right. There are grants. There are HIV grants. We do a lot of HIV care. So there's state and federal grants, Ryan White dollars. From HRSA, there are dollars that go directly to the FQHCs to support the provision of uninsured, providing services to the uninsured. But there are state grants, there are city grants. You have to be really creative and competitive in seeking these grants. Sometimes it's for women's health, sometimes it's for children, et cetera.
How many clients are we talking about?
We serve about 75,000 to 80,000 individuals a year.
Now, are we talking about, can low-income clients, can they come to you? You know, we hear about low-income people going to emergency rooms, and that becomes their primary health care. Can they come to you and have a regular doctor, a regular gynecologist, a regular podiatrist, or
right, Sheryl, that's a terrific point. Yes, there has to be, and it's important to have continuity of care, because not only does the provider have to know the patient, but the patient has to understand and get to know the provider. So there is a partnership, not just a doctor saying to a patient, I want you to do X, Y, and Z and come back. People have to get to know each other and figure out how best to care for that patient, and the patient to see how they can get the most out of that visit. So yes, someone who comes to one of our centers should be seeing the same doctor every time. If the doctor is on vacation, that medical record is shared with the provider who's covering, and there's a conversation that takes place. So we work as a team, and that's the important thing of a community health center. You have a provider, a doctor, could be a nurse practitioner or an MD, but that's just one part of the team. You have a nutritionist, you have a social worker, a health educator, maybe a mental health therapist, an HIV counselor, dental care. So it's all working as a team to look at the needs of that patient.
Can one come, we talked about the mental health people, can one come and get ongoing therapy?
Yes.
Weekly therapy if they need
Yes.
it over a period of time?
Yes.
Okay. There have been a number of cases where local politicians, I think some assemblymen, some senators, some city council members, have been running community health organizations that have received large amounts of city money, and I assume federal money, and the money winds up being cash cows for the politicians and their families. How does that happen? I assume, I hope these are not federally licensed clinics like
I'm not
yours.
aware of any clinics such as that where there's been any sort of accusation like that. That's horrendous. And one of the things why it's more difficult, there are very active boards of directors that have to be independent. There are conflict of interest clauses where someone on the board can have a financial interest in the organization, be a relative, et cetera,
Right.
or at least have to disclose it. That independence is really critical. If you look at these organizations that get into trouble, there's no independence. The CEO controls the board, basically controls everything. No one's looking at where the money's coming from and where it's going. And also the federal government and state, they scrutinize everything around federally qualified health centers. They want to see where every penny is spent. So it's a lot harder. That doesn't mean there can't be some fraud. I mean, you never know. I mean, I'm not aware of any in my organization, but there are a lot of safeguards put in place to make sure something like that does not happen.
Right. We're going to take a short break, then we'll be back with more with former State Senator Catherine Abate, President and CEO of the Community Health Network, after this message.
Did you know CUNY leads the way for students with disabilities?
CUNY Leads means linking employment, academics, and disability services. If you're a CUNY student with a visible or invisible disability, the City University of New York offers eligible students free career development and placement services. To find out if you qualify, visit cuny.edu/CUNYLeads. CUNY Leads, to the career I always wanted.
Welcome back to One to One. I'm Sheryl McCarthy of the City University of New York, and I'm talking with Catherine Abate, President and CEO of the Community Health Network. Now, obviously, you provide family planning, gynecological services, because that was where you started. I assume that this does not include abortions because of the federal ban on funds to places that perform them. Okay.
And in fact, because we get federal dollars, we can't do medical or surgical abortions. But obviously all kinds of contraception, health education,
prenatal care,
everything.
Right. Do you have programs for teenagers, specifically for teenagers?
We do, and it's one of the most important pieces of the programs that we run. We see about 18,000 teen patients a year, and they come to us. Some of them are quite knowledgeable, and others are not knowledgeable about their care. And we've taken on a model where teens working with teens. We have a Teens Pack program where teens actually go into the schools, go into other community-based organizations, do workshops, educating teens around not just about sex, but about healthy relationships, about how to use the internet, how to overcome your fears, lack of confidence. So many things are going on with teens. But what's very important is that our providers and all our staff are trained to be teen sensitive. No teen wants to go to a health center and say, you should be ashamed of yourself, or, why are you doing this? They want someone who's going to listen, to be professional, to give good advice, to give alternatives, but respect the teen where they are today.
What kinds of health issues are we talking about, which I've forgotten? I mean, other than maybe acne.
It's STDs.
Yeah.
It's HIV. It's pregnancy. They're close to, I think it's about 20,000 teens are getting pregnant. every year, and about 90% of those pregnancies are unintended.
Right.
But lots of things are going on with teens. Unhealthy relationships.
Right.
Not involved in safe sex, not using condoms, not using contraception, or not understanding contraception. So it's really to help that teen start a healthy life and making independent, healthy decisions for themselves. So when that woman gets pregnant, she can teach the same things to her children and the rest of their family.
Right. Now, HIV treatment, what are you seeing nowadays? I mean, we don't really hear much about it, you know, what's happening with HIV. I mean, what are you seeing in terms of the number of AIDS patients, the number of new cases, the kinds of treatment?
Right.
What are the big issues these days?
We're leaving out women. Certainly there's an increasing number of cases among women, and so there has to be education. But young gay men, too. That all of us grew up, and in the 1980s we saw the devastation of the disease. There was a face, it was a friend, it was a loved one, it was a neighbor who had AIDS and died within usually weeks or months. We saw the devastation. Today, people say, well, it's a chronic disease.
It's being managed.
I'm going to manage it. I'm not going to worry about it. And so people are not taking the preventions that they should. And we have to constantly keep that campaign going because there's far too many new cases every year. And many of them can be prevented if we do better outreach and better education, particularly among young people.
Right. How have you and your clients been affected by the Obama administration's health care reform? I'm not going to call it Obamacare because I hate that name.
Well, we're just going to begin to feel the impact of it. I mean, there are some good things that have already been in place. Certainly, young people up to the age of 26 can stay on their parents' insurance.
Right.
That's huge. As a result of that, there's a far greater number of young people insured today, because those are the people that aren't working, or they are working, their employer is not giving them insurance. What will happen come October is there'll be open enrollment, and people will now be able to enroll in the exchange, which will be offering private insurance to the currently uninsured today. And that undocumented individuals are left out. They can't even buy into the exchange. But if you are anywhere from 133% of the federal poverty level up to 400% of the federal poverty level, you can get subsidies and tax credits.
Are you required to get insurance?
It's mandatory.
That's what, yeah, okay.
It's mandatory. Now, what is not clear to me yet is what will be the penalties if you don't. And it's not, and how affordable is it going to be for working families when their first issue is food on the table and paying rent? And they're used to going to the emergency rooms. That's their primary care doctor. You know, it's going to take some time for one to make it affordable, to see what people can really, if families can afford to pay. And there are going to be some people saying, I'm going to opt out.
Right. Right.
And then there's also the smaller employer can also avail themselves of the help of the exchange. But all of this is new territory.
Yeah, yeah.
So it's going to be a wait and see. And then we have to deal with, there are going to be 1 million more enrolled people. There'll still be escalating uninsured because there'll be new undocumented people or people who are making more money than when they were on Medicaid, and they're going to be becoming the working poor. And maybe not affording. So there'll always be this large number of uninsured.
Now, where do the undocumented go? Now, they
come to us.
Do they come to you?
Yes. They'll use the emergency rooms, but it's they're not covered.
Yeah.
Unless you're a child and you're a pregnant woman, you are covered. But other than that, you're not covered through Medicaid, Medicare, et cetera.
So they have to pay something?
They have to pay something.
Okay.
But a lot of those individuals don't know that there's health care available to them.
What have you seen? You've been at CHN since 1999. What change have you seen changes in clientele or changes in needs in that time?
The communities we serve, and we're in some of the poorest communities throughout New York City, we still see the same struggling families. They're trying to make ends meet, do the best they can for their families. It's not easy. Living in New York City is becoming harder and harder, that gap in terms of affordability. And what I think, though, is better, and I think through the health centers, the work we do and the work of other federally qualified health centers, we are seeing some reductions in some of the chronic diseases that, at least with our patients. Because
such as, for instance?
Diabetes, cardiovascular disease, obviously obesity is still a huge, huge issue. But the movement is not
How about
away.
asthma? I mean, you want to see
And asthma, clearly asthma.
Down or?
It is for our patients.
Okay.
But we need to do more of that. If a family and their children are not in primary care, and some of these diseases are not managed, over time they're going to get worse, and people are going to end up in the emergency room or in hospitals. So it's very important, wherever you want to go, that families take their children and themselves for a primary and preventative care at an early age.
What are the biggest gaps that you see in our healthcare system, which would probably fuel another show? But
access, affordability, access to care, shortage of primary care doctors in New York City. I know there's going to be a huge effort through the Affordable Care Act to train more primary care doctors, to give them loans and incentives to practice in underserved communities, like where we are in New York City.
Right.
Because, and actually have providers who want to do primary care and not go into specialty care, where they can make more money. And then also train more nurses to become nurse practitioners, to elevate their level of practice. So there's a lot that has to be done to increase the amount of providers in the communities. We have to extend our hours longer into the night. Past 5 o'clock. We're on Saturday. Many people are open on Sundays because I think that's going to be, people work. They don't want to take off from work to see their primary care doctor. Then that's why you see just an overuse of emergency rooms. But there is a move towards electronic health records. We've had electronic health records for 4 or 5 years. That's essential. If we're going to be a patient-centered system where hospitals and specialists and homeless shelters and primary care providers and substance abuse programs work together to provide the needs of that patient, we're going to have to be able to share the data and the information about that patient. So electronic health records and the ability to connect with each other is going to be critical to the future. And outcomes. It's not about how many times you see a patient, but we're going to be judged on how we're improving the health of that patient. What are we doing to communicate in a way so that that patient, when they leave that exam room, is better equipped with greater knowledge to make healthier decisions in their lives, whether it's diet. I'm huge, I just overcame, well, you never overcome cancer, but I'm in remission, and I understand how important diet is. But very rarely, I'm sure of the listeners in this program, how many times has your provider talked to you about the importance of nutrition in prevention? And not just preventing obesity, I mean actually adding to your nutrition. So that your baby, and I say to people, it's not about being thin. It's not about the way you look, it's about being healthy.
Yeah, we had Maria Cuomo on a few months ago. She's written a book about,
Margaret.
About
yes.
cancer treatment and stressing the prevention. Because that's where you can affect it. The whole treatment thing is iffy.
And it's also if you put all your eggs in one basket, as chemotherapy, it works for some people, it doesn't work. Sometimes the disease is caught too late, and sometimes you just have to be incredibly lucky to overcome it. And you have to do everything you possibly can, mind, body, spirit, to overcome it. But nutrition is so key, because what you feed your body every day decides how strong your body will be to confront all diseases.
I'm afraid we're out of time, but I want to thank Catherine Abate for joining me. If you'd like more information about the network, go to their website at chnnyc.org. For the City University of New York and One to One, I'm Sheryl McCarthy. If there are any people you'd like to hear from or topics you'd like us to explore, please let us know. You can write to me at CUNY TV, 365 Fifth Avenue, New York, New York, 10016, or you can go to the website at cuny.tv and click on Contact Us. I look forward to hearing from you.